I am a mental health nurse trained by background and also a family therapist.
And the preparation of the presentation today was also supported by Dr. Erica Cheney, who's a consultant adolescent psychiatrist, and she's also the clinical team lead. So we all work for the East London Community Eating Disorder Service for children and young people, so all under 18. And we'll talk a little bit more about our service a little bit later on. Katie, do we have enough numbers to continue, do you think?
Yes, I think so. We're on 30 now, so any additional ones we'll be able to pick up as we go on.
Great, sure, okay. Let's see if I get this working. So these are just our affiliations and declarations of interest of the 3 people involved in the presentation today. And these are what we're going to go through today. So we're going to give a bit of an overview of the different types of eating disorders and a bit of an update on them. But we're going to particularly focus on ARFID and kind of the distinction between fussy eating and ARFID. And we're going to think about kind of the early warning signs and symptoms of eating disorders, which you might find in primary care, and describing kind of the best practice for the initial assessment in primary care and what immediate support to give. And then we're going to give some information about our service and how to refer and when to refer. And then we've got some case studies which we're going to go over of kind of a variety of different types of eating disorders. And then we'll do some questions at the end. So I just wanted to start with a bit of a relevance of today's update with some statistics. About 1.25 million people in the UK have an eating disorder. That's including young people and adults. And anorexia nervosa has the highest mortality rate of any of the psychiatric disorders. And eating disorders account for nearly a quarter of all of psychiatric disorders in children and adolescents when they're admitted to an inpatient unit. And these tend to be the longest length of stay of any of the psychiatric admissions. The average is 18 weeks. And the cost of healthcare for eating disorders in England is 80 to 100 million, with kind of much higher overall economic costs of 1.26 billion per year. And I guess one of the key messages we want to give in this presentation is that the earlier the eating disorder treatment is sought, the better the sufferer's chance of recovery. And we've got quite a big focus on kind of picking up early signs and talking to you about our kind of early intervention pathway and kind of how we manage sub-threshold eating disorders. So this takes me into, I guess, a bit about the spectrum of eating behaviours, because it's quite difficult to always put a person in a diagnostic box. And it's not necessarily a case of eating disorder or not eating disorder. There's a range of eating behaviours ranging from kind of being a healthy weight, having a healthy exercise and eating habit, and having a good relationship with body image. But we live in a world of huge diet culture. We also live in a society where obesity is a huge problem, and there's a lot of focus from the government and the healthcare about reducing weight and obesity. So it's very common, it's particularly in the younger population and teenagers, to see, you know, poor body image and some weight preoccupation. And that doesn't necessarily always tip into an eating disorder, but it is a kind of predisposing risk factor for tipping into an eating disorder. So we're going to talk a little bit about what normal eating is. I think it's something we don't think about a lot. Oops, sorry, that was my fire alarm making a funny noise. There's not a fire. But I guess in summary, normal eating is flexible, and it varies tremendously in response to kind of not just our hunger levels, but also things like our emotions, our proximity to food, which is, you know, everywhere these days, and also just things like our daily routine. So it's, you know, being able to eat when you're hungry and continue to eat until you're actually satisfied, being able to choose foods you like, eat enough of them and not just stop eating them because you think you should. It's also, you know, overeating at times, and I think the key thing is at times, and undereating at times, and trusting that your body's going to kind of make up for lapses in your eating, and giving yourself permission to eat for other reasons than hunger because it just feels good. And eating should take up some of our time and attention, but it's kind of keeps its place in moderation, that just only one area of our life and doesn't become kind of all encompassing. And, normal eating is having enough control to get a good balance of food that we get the right nutrients, but not so much control that we're missing out on treats and pleasurable foods. So I think that just puts into perspective a bit, if we think of the opposite of that, what that might look like when we think of disordered eating. So, I mean, a variety of abnormal eating behaviours by themselves don't warrant an eating disorder diagnosis. There are, probably you've all met a few people with quite strange eating habits, but having disordered eating behaviours, particularly dieting, is one of the highest risk factors. So some of the kind of early signs and symptoms of disordered eating may be frequent dieting and having anxiety related to specific foods or skipping meals, just rather than being flexible with eating, just being quite rigid, having rituals or routines, and these can sometimes link to exercise behaviours as well, and having quite strong emotions connected with food, shape and body weight. So often things like feeling guilty, feeling ashamed about what's been eaten, or if exercise has been missed, and just a general kind of preoccupation with it. Feeling a loss of control around food, even if there isn't a loss of control, that feeling of a loss of control. But in some patients, there may be an actual loss of control. And kind of using compensatory behaviours like exercise or restriction or purging to make up for bad foods. So when it tips over into an actual eating disorder diagnosis, actually I think I'm handing over to you now, Natasha, aren't I? Oh, I can't hear you.
Thanks, Michelle. Now, I'm going to talk about the eating disorders in a bit more detail, and when it does tip over into disordered eating and what the different types of eating disorders are. So there are 8 types of eating disorder, which are defined by abnormal eating habits that negatively affect a person's physical or mental health and impacts on their psychological and social functioning. So the most well-known eating disorders are anorexia nervosa and bulimia nervosa, but even those are the most well-known, the most common eating disorders are not those. They are the other specified feeding and eating disorders and unspecified feeding and eating disorders, which we're going to go into, clarify what those are. Thanks, Michelle. The main types are, as we said, anorexia nervosa and bulimia nervosa. And there's also binge eating disorder, which I think people are a bit less aware of, and it's a newer diagnosis and has a bit kind of less research and evidence in relation to it. And there's also other specified eating and feeding disorders, and that's called OSFED, and that is also quite a new category in the DSM-5, which used to be referred to EDNOS, so that was eating disorder not otherwise specified. And I think the difference is that there are kind of more categories within OSFED that kind of describe each different kind of distinctive type of eating, type of disordered eating within a category, rather than just lumping everything into unspecified. And other types of feeding and eating disorder are avoidant restrictive food intake disorder, which is called ARFID, rumination disorder, and pica. So we're going to have a bit of a look at these. So just to think a little bit about risk factors for eating disorders. So there's never one cause for an eating disorder, but we look at a kind of biopsychosocial model and look at the different risk factors that might make somebody vulnerable to developing an eating disorder. So just to break this down a bit, there's psychological factors. So if somebody has low self-esteem and has personality traits that makes them quite perfectionist or competitive, they're often young people who are highly concerned with what other people think about them and opinions of others, and they're often quite prone to black and white thinking, and prone to extremes. So rather kind of than being relax with a kind of middle ground or uncertainty. They want things to be very clear and certain and black or white. In terms of biological factors, the adolescent time period where there's lots of different changes going on physically, in terms of hormones, but also in terms of life cycle transitions, and kind of peer relationships. It's a time of big change, and that all can add stress to a young person's life. Other biological factors are genetic or familial factors, and there's been a link found to chromosome 1, and also there's been kind of twin studies that show there's 58 to 74% of heritability in anorexia nervosa, and we know that these genetic effects increase after puberty. Other biological factors are when a young person has feeding problems early on in their life, in their infant years, and being female also makes one more prone to developing an eating disorder, and we'll talk a little bit about that later on when we look at prevalence. So in terms of external factors, stressful life events such as separation of parents or moving schools have an impact, as well as teasing or bullying, peer pressure, dieting, and kind of social and cultural factors, and peer kind of beliefs about body image and healthy eating. Troubled personal or family relationships, and also experiencing abuse, or will make a young person more prone to developing eating disorders. And also social factors, so pressure to achieve and succeed, whether that's in school or in the family, and also entering into or having pressure to pursue careers that have an emphasis on body shape and size, so being an athlete or a model make people more prone to developing eating disorders.
I also just wanted to add something around the kind of teasing of bullying or shape or weight. It doesn't necessarily even have to be teasing. It could be just something that's pointed out in early years. So we've had quite a lot of young people in our service who developed an eating disorder after their year 6 weigh-in, and parents received a letter kind of highlighting that they're overweight and what the health concerns are. So I think that's something that's very topical at the moment, with the kind of discussion around whether we should be weighing children in school after the pandemic.
I think also just school talks that are very heavily focused on obesity and avoiding sugars and fats can really, for those young people that are prone to being very perfectionist and competitive, or have those other risk factors that we've spoken about, can have a really big negative impact. Should we move on, Michelle? So in terms of anorexia, the updated diagnostic criteria is that it is a persistent restriction of energy intake leading to significantly low body weight, which is less than minimally expected weight in children and adolescents. And individuals must no longer explicitly endorse or articulate a fear of weight gain, but rather there may be a persistent behaviour that interferes with their weight gain. So that's slightly different to what it was previously, that they don't have to state or express that they have that fear in relation to weight and shape. But they will have a disturbance in the way their body shape is experienced, or their weight, or they might have a lack of recognition into the seriousness of the current low body weight. So I'm seeing a patient at the moment who has just been hospitalised and is very low weight and on the brink of potentially being admitted to another paediatric ward, and they can't recognise that they're low weight. They still think they need to lose weight, and don't see kind of what all the fuss is about, which kind of shows that there's a disturbance in their perception of their body. So the amenorrhea criterion has been eliminated, but it is something that we still look at in terms of assessing whether someone might have an eating disorder. So we've also prepared a handout that people can look at in their own time, just looking in a bit more detail at the medical signs and symptoms of anorexia.
I think I just need to comment that I guess the new updated diagnostic criteria helps capture some of the young people who maybe don't have the fear of fatness so much, but it's not kind of as easily expressed. And I think that's really helpful that that's been updated, because eating disorders can be very secretive, and often sufferers don't want help, so they may try and cover up their symptoms. So by updating the diagnostic criteria to look at the actual behaviours, we're able to capture those young people and offer them support.
So bulimia nervosa and binge eating disorder is where an individual consumes an unusually large amount of food in a discrete period of time, and then experiences a loss of their sense of a loss of control over eating. And there's objective versus subjective binges. So a subjective binge is where the young person would describe what they've eaten as a large amount, but somebody else looking at that would not describe it as a large amount. An objective binge is where typically people would agree that that was a large amount of food. And so that can help distinguish the difference between binging and overeating, but other factors that distinguish those is that feeling of a loss of control, often eating more rapidly than one usually would, and it being in a discrete period of time. And also when it's a binge, in terms of diagnostic criteria, there would need to be a marked distress associated with that binge, whereas someone who's overeating might not experience that same distress. So for bulimia nervosa, binge episodes and compensatory behaviour occur at least once a week for an average of a 3-month period. So if it was less than that, it wouldn't meet the criteria, but often it's more than that. And for binge eating disorder, that is this similar criteria, but they don't have the inappropriate compensatory behaviour that is required for a diagnosis of bulimia. However, marked distress around that binge behaviour is present. And we're going to look a bit more at compensatory behaviours and what they are.
And I think just to comment with the binge eating disorder, with younger children, sometimes it can be difficult to distinguish whether there is distress, but it's an important part of the diagnostic criteria, because we think of young people with learning disabilities who may kind of be overeating but not evidently distressed, and that is something completely separate to binge eating disorder.
And much more prevalent. There's a lot of overeating in society, and so yeah, that distinction is really important. So the types of compensatory behaviours are self-induced vomiting. So that might be the stimulation of the pharynx using a finger or a narrow object, and is often facilitated by drinking lots of fluids. Sometimes people might drink salt water to induce vomiting. And some people, particularly if they've been vomiting for a long period, can kind of learn the ability to vomit without that stimulation. So they can kind of squeeze their abdominal muscles and can kind of reflux and vomit without doing that. Some people that vomit regularly will develop reflux and regurgitation and spontaneous vomiting, so they can so it becomes a kind of a learned reflex on eating, and becomes much more out of their control. Other types of compensatory behaviour are laxative misuse, so that might be diet pills, diuretics or other medication, such as thyroxine, and things like Movicol and other kind of laxative stimulants, excessive exercise, is common compensatory behaviour, and we would kind of look at the amount and frequency of exercise, and also kind of how driven it is, whether someone gets enjoyment out of it or if it's something that they feel they need to do. And often people might develop an unhealthy kind of fasting and restricting pattern and then binging, but restricting intake is a way of compensating for feeling they might have eaten too much. Or some young people might not use or misuse their medication, such as insulin, as a way of kind of compensating for intake that they then feel guilty for. So the binge purge cycle, it often looks like very strict dieting or restricting, then slipping if they if a difficult situation arises, or something happens and they do then break their kind of dieting rules, and then kind of feel a loss of control, which is partly because the body's starved and wants to take in lots of food, and then the young person will feel quite guilty and ashamed, and want to purge and get rid of those calories through these behaviours. And it's associated with really strong feelings of shame and self-hatred, which then restarts the cycle. And again, there's a handout with kind of a bit more detail about the medical signs and symptoms of bulimia. So again, just to talk about the impact, anorexia has the highest mortality rate of any psychiatric disorder, which is from the medical complications associated with the illness, as well as suicide. And so that is the strongest out of the different types of eating disorder, the highest mortality rate. Bulimia is associated with severe medical complications, which can include death. I think often people associate just anorexia with the mortality, but it can come with bulimia as well. And binge eating disorder sufferers will experience medical complications that are usually associated with obesity. And so the other specified eating or feeding disorder can include things such as atypical anorexia, where all the criteria met for diagnosis of anorexia, except despite significant weight loss, the individual's weight is within or above the normal weight range, but they can still have extremely strong compulsions to engage in compensatory behaviours, or have those same that same fear of their weight and their shape, that drive their desire to weigh less. Binge eating disorder of a low frequency or kind of acute periods that isn't a long-term duration, which is self-explanatory. It's less frequent or not occurring for as long. And for bulimia, bulimia of a lower frequency or limited duration. So the binge eating and compensatory behaviours occur less often and not for as long. There's also purging disorder, which is where young people will purge in the absence of binge eating, but they also don't meet criteria for anorexia or bulimia. And also night eating syndrome, where people have recurrent episodes of night eating. And I think now we're going to move on to the ARFID diagnosis, and some other disorders that Michelle's going to talk to us about.
Thank you. So avoidant restrictive food intake disorder, it's an eating or feeding disturbance which is kind of manifested by this persistent failure to meet kind of the appropriate nutritional needs. So that could be kind of micronutrients and energy needs, so the calorie intake, and it needs to be associated one of the more of these following. So significant weight loss. It's more common in younger children, so we may not necessarily see significant weight loss, but we may more likely see faltering growth, or it could be significant nutritional deficiency. And I guess we really need to think about what's significant here, because a lot of obviously young people in the UK may have a vitamin D deficiency. So we're really looking at more significant and kind of definitely related to their dietary intake, or dependence on enteral feeding, or oral nutritional supplements that they, if they weren't to have that, they would be losing weight, or a really marked interference with psychosocial functioning. And I guess this is the point where we need to really consider how marked it is, and it needs a bit more in-depth assessment. But we're thinking about, children who really struggle to eat in different environments, such as school, can't eat the school meals, or when parents are taking them on holiday, they have to fill a suitcase full of spaghetti hoops, something where it's really kind of markedly difficult and it's interfering with their life. The ARFID occurs when it's kind of not better explained by lack of food. So, it wouldn't be in cases of deprivation or neglect, or by a kind of a cultural practice, like kind of fasting for religious reasons. It can't occur kind of exclusively during a course of anorexia or bulimia, but I guess it's worth pointing out that having ARFID and kind of these feeding difficulties as a younger child does put you at risk of developing anorexia and bulimia when you are older. So it can be kind of, young people can move from kind of one diagnosis to another. But one of the key things with ARFID is there isn't a disturbance in the way weight and shape is experienced. And often a way we would distinguish this in our clinic is we would ask them, if we had a magic wand and we could make you reach a healthy weight, a child with ARFID would say, yeah, great. But a child with anorexia, that would be the last thing they want to happen. With ARFID, it can't be attributed to kind of a medical issue or another mental health disorder. But if it's so extreme that the eating needs attention in itself, on top of kind of another mental disorder, for example, it's often very common in autistic spectrum. So that you could get a diagnosis of ASD and ARFID as well. So the feeding and eating disturbance, that tends to be kind of three main areas in the way it kind of manifests. And these are the sensory factors of food, just a lack of interest in food, and the fear of the consequences of eating. And most young people with ARFID have a combination of these different barriers to normal eating. So I'm going to go through a little bit more detail of what these look like in kind of actual practice. So lack of interest, it's often an appetite issue. There's a difficulty to recognize hunger. Young people forget to eat, need a lot of prompting. Their eating changes due to their emotional states. That can be, to quite an extreme extent, where if they're feeling low or anxious, eating is one of the first things to go. And it can even be positive emotional states, such as being too excited to feel like eating. Eating can really be experienced as a chore. Foods aren't enjoyable. Some young people need distraction to eat, so they may need to kind of be on their computer game or watch TV to be able to actually eat. And they can often feel full very easily, because with these young people, they're often eating very slowly, and therefore they do get fuller more quickly. And it's the young people's lack of interest that often leads to being a low weight or faltering growth. One we see quite a lot of this is the sensory factors, and these are kind of sensory sensitivities to kind of variations in the taste, kind of appearance and texture of food. So with the appearance, it could be a strong loyalty to different colours, for example. Not wanting a biscuit if it's a little bit broken, or if there's something doesn't look quite right, like a bit of the edge of a chip is a little bit burnt. So it's really kind of very sensitive to those, and it's all about safety. So foods that look similar are safe foods, and these tend to be beige foods, because beige foods are manufactured foods that have a lot of quality control. And one digested biscuit is going to look very similar to another digested biscuit, but a broccoli isn't going to look similar to another broccoli, and it's not going to feel the same necessarily. So children with the sensory factors tend to be more on a kind of beige carbohydrate diet. They can get quite sensitive to having different brands, and actually the food label can be important. So if a label changes, for example, they add a promotion to it, that can actually mean the child doesn't want to eat that food anymore because the label's changed. Therefore, they don't know if that food is still the same and still safe for them to eat. There can be temperature preferences for different foods, which can be challenging if you've got a child who's a slow eater and then they like a food to be warm and then it goes cold. And then when it's reheated, the texture changes because it's been reheated, and then that sensory difficulty comes in. So these kind of different barriers to eating do intertwine quite a lot. A lot of the young people have kind of fears around food touching each other, whether it's even if it's light foods that are touching, they like things to be kind of very separate, and they're often quite sensitive to mixed texture foods such as yogurts with bits in them because they kind of come as a surprise. They tend to prefer kind of smooth, consistent textures or melt in the mouth textures, things like hula hoops or skips or chocolate, things that aren't kind of don't need as much kind of chewing and kind of oromotor skills in the mouth. And they tend to have kind of more general sensitivities. So that can be oral sensitivities, such as brushing their teeth, but also more general things like the texture of their clothes or just to kind of noise and crowds. And that can make experiences such as eating at school very difficult. And with these different sensory sensitivities, it can be a combination of actual fear of the food or disgust. And these are the ones that are this kind of barrier is most strongly associated with autism, but not always. We have seen it in children without autism, but generally I would say would screen for autism if we see a child who's very sensory sensitive. And then the other one is the fear of consequences, and these can be kind of vomiting, diarrhea, choking, allergic reactions or pain, and they tend to be more prevalent in the anxious children. And these tend to be kind of triggered by kind of a negative experience or witnessing others. And the kind of fear of choking can often be linked to an aversion to foods perceived as difficult to chew or swallow. So this is how it can link in with the sensory factors. And in extreme cases, when the fear is really strong, it can lead to kind of a really acute episode of food refusal. We've had to occasionally feed young people via an NG tube for a period of time because they've just been too terrified to eat. And there's been examples such as a really embarrassing incident of vomiting in a restaurant or getting like a bone stuck in their throat. And I guess when we've seen these behaviours such as fear of vomiting can also lead to kind of other fears around kind of hygiene and such as eating in the canteen, best before dates, and also can mean they restrict the amount of food they eat because they don't want to feel uncomfortably full because they worry that may then make them feel sick. And there can be quite a lot of kind of safety behaviours such as small bites, sipping on fluids, and eating really slowly seen in these children. So just as a bit of an overview, I guess, trying to distinguish between fussy eating and ARFID. I mean, neophobia, fear of new foods and food refusal is a really normal part of toddler development, and young children do need to try a food many times, things like 10 to 20 times to accept it. ARFID's different to fussy eating, neglect, deprivation, and systemic and behavioural issues. Children can refuse to eat food for various reasons. ARFID can actually occur across the ages, and it can either be chronic or have this acute onset, and that's more linked to the fear of aversive consequences. And it's often associated with a kind of psychiatric comorbidity, especially with kind of anxious or obsessive compulsive features. And with the intervention, what we do is we kind of focus the treatment on the kind of where the category of disturbance is most present. So there's not much evidence as of yet, but there are some kind of early studies on what helps in different interventions, kind of family and individual interventions for ARFID, but treatment progression can be quite slow. So with their young children, we end up following up for quite a long time. So we're probably going to go through these quite briefly. Pica and rumination disorder. I mean, Pica is the eating of non-food substances, and it needs to be kind of inappropriate to their developmental level. So it can't really be diagnosed in under twos because they're always putting things in their mouths. And not part of a kind of culturally normal process. For example, I know in some cultures, you know, there may be non-food substances kind of eaten, and not in the context of another mental health difficulty or medical condition in pregnancy. Women pregnant may crave particular substances. It's different to kind of in the context of self-harm. So young people may eat non-food items such as batteries in the context of self-harm, and also, you know, it can be used in kind of anorexia and bulimia to suppress appetite or trigger vomiting, but it would be something kind of separate to that. We don't see pica kind of, we're not the team for pica, but if it's related to a kind of additional eating disorder, then we may come across a pica patient. But I've worked in our team for 4 years and I haven't met a patient with pica, so it's not very common. And then rumination disorder is the repeated regurgitation of food for a period of at least a month. And the regurgitated food can either be, you know, rechewed, re-swallowed, or spat out. And it's different to kind of a medical condition such as reflux or kind of another GI condition. And kind of if it is present in the context of another difficulty, it's severe enough to warrant additional clinical attention. So it's a little bit unclear whether how kind of intentional and voluntary it is. It can become a very habitual learned behaviour. It can often be experienced as pleasurable and kind of re-experiencing the sensation of eating, and it can be kind of a self-soothing repetitive behaviour for emotional regulation, particularly in learning disabilities. But others may try to avoid eating to avoid the rumination because it's, you know, it's an embarrassing habit that they have. So I'll hand over to Natasha to talk about the prevalence.
Yeah, so prevalence of eating disorders, this first diagram has come from a GP database between 2000 and 2009 and had 9,120 patients from 10 to 49 years old with the first time diagnosis of anorexia, bulimia nervosa or EDNOS. So this was done before it changed from EDNOS to OSFED. So it's important just to note that when this was done, they haven't been looking at things like ARFID or binge eating disorder or purging disorder. It's just been those three categories. But here you can see that the highest incidence was of EDNOS, so that is kind of eating disorder not otherwise specified. And then the next highest incidence was bulimia, and then at 23.5% was anorexia. And the incidence was highest for girls aged 15 to 19, and then for boys at 10 to 14, so a slightly younger age of onset for boys. And overall, we see that in eating disorders, 75% of sufferers are female and 25% male. Hence, the being female is a kind of predisposing factor. And overall, looking at eating disorders, a few different studies have showed that in adolescents, the prevalence is 1 to 2% for bulimia and 0.3 to 2% for anorexia. And a study in the US showed, because there's less evidence and statistics around binge eating disorder, but in the US there was a study that showed it's 1.6%. As Michelle was saying earlier, there's much less research on ARFID, pica or rumination disorder than there are for anorexia and bulimia. It's a relatively new diagnosis, so there's less out there, but in Switzerland a study of 1,444 children found a 3.2% of children reported ARFID features. And next is a diagram just looking at the different kind of ages of onset for bulimia and anorexia. So anorexia first shows signs at an earlier stage, and bulimia nervosa is more likely to to begin in later adolescence, into the kind of early and late 20s. And this just shows what the KEDS referrals have been in 2019 to 20, and so you can see there that the highest category that we treat is anorexia, and the next is atypical anorexia. And then, no, sorry, I've got that wrong. The next after anorexia is actually not, the highest number is in cases where we don't give a diagnosis. And that, I think for some of those we might refer on to other services, and for some of them we might treat by using our early intervention pathway. We might feel that they're at risk of developing an eating disorder, or provide some treatment that addresses the type of eating disordered symptoms that we see. But yeah, that's the highest category after the anorexia, and then it's atypical anorexia, bulimia nervosa, and other eating disorders such as ARFID and binge eating disorders, and a similar number for OSFED and purging disorder, and then the least number is for atypical bulimia. And so there's some, we've got a handout that goes into a bit more detail about this as well, but just as an overview, there are guidelines from the Healthy London Partnership for GPs and primary care professionals that are really useful, just as a really quick reference to think about when you see a young person that you think, okay, is this an eating disorder? It's really useful to refer to this. So it's knowing the first signs and when to refer. Really bearing in mind that the earlier somebody is seen, the better their chance of fully recovering from an eating disorder, and the longest that symptoms persist without being picked up and treated, the harder it's going to be to retract from those difficulties. And children and young people don't need to be exceptionally underweight for a referral. They might have some worrying signs but not show the underweight, but it's still really important to refer that on so it can be assessed, and then something can be picked up, or they can be signposted to where they can get support. But I think it's a common myth that it's just people that are underweight that might have an eating disorder. But binge eating disorder, or which can lead to obesity, really does have a massive impact on a young person's kind of well-being and development. So it's really important that they're picked up as well. And so, yeah, refer all suspected children and young people with eating disorders to your local KEDS team, which is us, the Community Eating Disorder Service. Include a physical exam in that referral, and so that would include doing their weight and height, taking a blood pressure and pulse, temperature, and to send, for our team, we do blood tests for young people, but sometimes it might be appropriate to do that in through the GP practice. But what's really important is that you don't wait for results to come back before you refer. Just get that referral in so that it can be picked up as soon as possible. So the first signs that can be really useful to look out for are whether family members report a change in eating, and you can ask a young person, are your family or friends worried about you? Get a bit of a history of what their intake is like, what they've eaten kind of the day before or in that last week, what their typical eating pattern has been like. Ask about compensatory behaviours, so are they over exercising, or are they maybe doing anything else to try and lose weight? Other factors that you can look at is whether they're withdrawing socially, particularly from situations that involve food. But like Michelle was saying earlier, it's a very secretive illness, and often young people might not be very forthcoming about some of these questions, but you can ask a parent, well, have you noticed a change in their kind of school engagement or seeing family, being at kind of family gatherings where there's food involved, and kind of find out through those kind of questions. It's important to ask if there are any other mental health problems that the young person is experiencing. So there is can be quite high comorbidity between eating disorders and other disorders. So we've mentioned possible ASD, but also things like obsessive compulsive disorder and depression and low mood, and self-harm. So it's really important to check out those things first, to give an idea of risk, but also they might require a different kind of treatment intervention that it's important that we identify, or an additional treatment intervention. It's important to try and assess whether there might be a concern about their weight or shape, but again, if somebody's not able to answer that, you can still look at what behaviours they're engaging in and what their weight might be doing, and also ask about find out whether there's chronic illness or other medical conditions that might impact on how they relate to food and eating, and explore if there might be gastrointestinal system symptoms that need investigating. So physical signs are usually either a low percentage weight for height, or can be a high percentage weight for height. So weight loss changes, we look at fluctuations, losses and gains, and if you don't have a weight to compare to, you can ask about whether clothes sizes have changed. A change in menstrual cycle is important to ask about, and cardiovascular health, such as bradycardia, postural changes. So we look at postural drop and change in heart rate on standing, and also look at poor circulation. So if they have poor circulation to peripheries, as well as any palpitations, those are really important signs to look out for. The blood tests will look at the electrolyte imbalance or hypoglycemia. There might be dizziness or fainting present, and often there's hypothermia, cold extremities and pallor, and cold sensitivity, so they might be wearing excessive clothes. There's often tiredness and fatigue because of the lack of weight, and muscle weakness as a result of the body using up muscle for energy. And atypical dental wear is something to look out for in bulimia, because of the erosion of the enamel through vomiting. And Russell sign is marks on the knuckles in the picture there, which is a sign of somebody self-inducing their vomiting. But that's a sign of quite an extreme level of vomiting. I don't think you'd see that if it was infrequent. And changes to hair, skin or nails, so we'd ask about that. So a really helpful just prompt is recommended by the NICE guidelines, validated for the initial detection of eating disorders in specialist and primary care services, which is SCOFF, and you ask whether somebody might make themselves sick because they feel uncomfortably full. Do you worry if you might have lost control over how much you eat? Have you recently lost more than 1 stone in a 3-month period? Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? And you would score 1 point for each question. Answered yes, and 2 or more points would suggest an eating disorder. And so that's a really helpful, just kind of quick screen. As I said, include in the physical exam these things, but don't delay referral for waiting for results. And it's also on the handout, but red flags which would require kind of urgent referral and assessment is not eating or drinking for more than 24 hours, cardiovascular compromise and fainting, being a lower BMI than 13 or under the second centile, and for BP being below the 0.4 centile. And for pulse it would be under 40 beats per minute, and a sitting and standing postural drop, and temperature of under 35 degrees. Also look at rapidity of weight loss, so anything over 1 kilogram a week for 2 consecutive weeks would be a red flag and want urgent assessment.
And just to mention, we're doing a follow-up teaching session in December, which is going to focus more on kind of risk assessment and management in eating disorders, including refeeding syndrome. So I was just going to talk about how we kind of assess and define malnutrition in young people and adolescents, because BMI is of little value due to their growth. So what we do is we look at percentage weight for height, which takes into account their age and their sex, and it's based on the World Health Organization growth charts. So it's calculated by their actual BMI divided by the median BMI, which would be the BMI if they were on the 50th centile for their age and sex. So generally, if they were on the 50th centile, their percentage weight for height would be 100%. For most young people, we'd expect the healthy range to be quite narrow, around about kind of 95 to 105. But of course, there's individual variation based on many factors, including genetic factors and ethnicity. And that's why we look at other factors, whether they are having a regular menses, what their cardiovascular measures are, looking at the SUS test, which is sit up, stand up test, and it's a way of checking on their muscle strength. And also another sign of low weight would be having a low white blood cell count. I guess we'd also be quite concerned if someone has a really high rate of weight loss, because this would increase the cardiovascular risk even in kind of normal and overweight young people. And if there's any failure to grow, so for example, their height is on one of the lower centiles, or delayed puberty, that's a sign of malnutrition in young people. So I've just got an example here of how the weight for height looks. So we've got a 13-year-old girl, and so the median BMI at 13 would be a BMI of 19. Her BMI is 13.7. So you do the division and she's 72%, which is very underweight. So just a kind of a summary for primary care, it's about collecting the relevant information, the signs and symptoms of a possible eating disorder, and do the physical health checks. Ensure the young person and the parents are aware and consenting the referral, and kind of complete the referral form in full. And I've got a handout, on the handout we've got our kind of contact details and a link to the referral forms online. But I would say if there's any urgent referrals, if there's any of the kind of urgent red flags, give us a call so we action it immediately, particularly if it's a Friday afternoon. You can give the family kind of information about our service by signposting into our website, and there's also some kind of signposting in the meantime. We have quite short kind of waits until assessment. Even for routine cases, we aim to do assessment within 15 days, but it might be helpful to kind of signpost some families to kind of the charity websites that are available, and just, kind of follow up any urgent concerns. And this is a copy of the eating disorder section in the CAMHS referral form. So try to include, the physical health information, and if possible, the date that the measurements were taken. Sometimes it's unclear if this is kind of a previous weight or one done at home, just so we can really kind of judge the risk. And if possible, kind of add in the weight for height. Include any kind of changes in weight, and just give a kind of a brief overview of the eating disorder symptoms, such as food restriction, vomiting, compensatory behaviours, and any details of the physical health examination. And then that takes us to our team. So this is a photo of some of our team members. Natasha's not actually in this one yet because she has joined us only quite recently. But what we offer as a team is kind of, we're a community service, but we do have paediatric outreach where we visit young people when they're admitted to the wards. We're all multidisciplinary and kind of work with various agencies, and we conduct the evidence-based treatments as per NICE guidelines. And what happens when we receive referrals is we'll initially screen them for their urgency, and we'll conduct a telephone triage call with the parents and young person, and that will also help us judge the urgency. And then we will send them for a full list of baseline blood tests and organise an assessment, which is kind of about an hour and a half long kind of speaking assessment with the young person and the parents, but we also would do a physical health assessment, including an ECG. And this is just the makeup of our team. So we are based in the 3 boroughs in East London. So we're based in Tower Hamlets, Newham and City and Hackney. And these are